Hello, everyone, and welcome to this week's episode on Fit as a Fiddle. Our guest today is Charlotte Mueller. Charlotte is a nurse practitioner at the Centers for Vulvovaginal Disorders in New York City. Our offices are like blocks away from each other, which is really fun. And Charlotte and I work together on some patient cases. She treats a lot of things around pelvic health and pelvic pain, and there's lots of different kinds of pelvic pain. So she's maybe going to touch on a couple of those in a second. And as an orthopedic and pelvic floor PT, there's so many interventions that she offers that are so important for our patients to heal and very necessary in a multidisciplinary plan of care. So, Charlotte, we're really excited to have you on the show today. Thank you for joining us.
Yeah, thanks for having me.
Absolutely.
It'll be fun.
Yeah, so for listeners to get to know you a little bit and what you do as a nurse practitioner in this field,
hmm
tell us a little bit about yourself and what brought you to where you are right now.
I think that as I was going through my career as a nurse, I was, thinking about what I like and don't like, what I'm good and not good at, what fulfills me and what doesn't. And I really found that I liked coordinating care, like helping people navigate the system a little bit. And I worked in oncology before this, and so there was a lot of coordination of that as a nurse. And helping people find appropriate resources. I also found that I liked talking about quality of life, like being involved in those conversations. So in the cancer community, like you call survivorship was some of the conversations that I enjoyed. Talking about how we can now feel good in our bodies after you've gone through all of the treatment. I like thinking about conditions that have multiple factors that are contributing to what's going on. It feels like creative thinking and problem solving, and I think that I find all of those aspects in treating vulvovaginal pain conditions. I like the ability to really be able to take time to hear a patient's story, hear where they're coming from, and hear what their concerns are and what they're asking for. I also got into the field of vulvovaginal pain because I was a patient first, and that was sort of my introduction to this world. I then took a step away because I had to process the whole experience, and I didn't want to you be treating patients before I fully understood how I was getting myself better. But I did get better, and I feel that it gives me a perspective of where patients are coming from and how difficult it is to navigate and how easily it is to be dismissed because it's hard to go to providers with these symptoms and then be told we don't know or at worst, it's all in your head, or there's tons of bad advice out there. And so I like working in this space and being able to um, really break down, the reasons for the pain and explaining why there is pain and why it's not all in your head and helping coordinate with all of the providers that are needed to treat these conditions. So we work with pain management specialists and physical therapists and all types of providers. So I think I addressed your question. I think all of those factors are why I like being in this field. So it's a combination of what I like about my nursing and nurse practitioner role and also my patient perspective. So.
I do love that. And I think that, while every cardiologist doesn't have to have had heart surgery and every person who's been a provider in some field does not have to have personal experience, I do think when it comes to a lot of this pelvic health stuff, it's nice to have some level of empathy and understanding for patients, and that can even come from a loved one or just a friend or just somebody that you know in your life or yourself going through that. Not that I ever wish that providers have the same problems, but um, it's really helpful because I think you come from a strong understanding of patient-centered care, and that's just so important in this field and all fields, but really in cancer field and oncology and in pelvic health and stuff that can really be hard to understand. That takes a lot of upper level expertise and training to be able to do. And so I think your patients are probably just so much more grateful for you and the type of bedside manner that you have and the type of understanding and the type of education you provide, probably because you've gone through something like that. I have a similar story with pelvic issues on my own end and overcoming that. So I always have a lot of empathy for my patients who struggle with these quality of life issues, as we've said.
Yeah.
Okay, so let's kind of jump into our topic today. Charlotte is in the middle of a research study, and so she is going to talk to us a bit about Botox as it relates to pelvic pain. So, we have a lot of misconceptions and maybe preconceived notions of the uses of Botox in the general public, right? So, people most of the time will typically see it as something that people use for cosmetics in various ways. So, Charlotte, can you please explain to our audience what is Botox in the first place? And then what are its uses from like a therapeutic sense versus a cosmetic sense? What does that look like?
Okay, so Botox is a neurotoxin, so it's toxic to our nervous system. So Botox specifically is called botulinum toxin type A. It comes from a bacteria called Clostridium botulinum. Um, and it works by disrupting the signaling between our nerves and our muscles. So it leads to a paralysis of the muscle temporarily. So drug manufacturers are able to get this toxin and purify it and put it in a powdered form. And then we basically reconstitute it in a solution and are able to inject it in small amounts intentionally to paralyze the muscle for either a therapeutic or a cosmetic effect. And so most people understand it from a cosmetic use when it's injected like just in the muscles under the skin. And so when those muscles are paralyzed, the overlying skin can't form those creases. I don't have Botox right now. And if I did, like no matter how hard I wanted to raise my eyebrows, I couldn't because the signal is blocked. So I'm telling my brow to rise, but acetylcholine, which tells them the muscle is signal molecule, the muscle doesn't receive it, so it doesn't move. And so it's blocked and it's temporary. It wears off. But therapeutically, it's used for so many different conditions that are involved with having too tight muscles. So TMJ, migraines, um, um, and it not only relaxes the muscle, but also does inhibit some pain signals. So it improves the actual pain of the condition. So this means that not only like the peripheral pain signaling is improved, but there has been improvement in central sensitization, which is something like that occurs when you have chronic pain. You can have heightened nerve signaling. Um, so even when there's no longer that acute injury or reason to have such a heightened pain signaling, but it can develop from having chronic pain. So Botox helps in both muscle paralysis and in pain signaling, um, which makes it really good for pelvic floor dysfunction. Um, so we are just starting our study. Um, actually screening our first patient is coming in New York for a baseline visit today. So this is pretty early on in our recruitment of participants. We're going to be recruiting 54 patients in totals over the next year and a half. So if you're thinking about it now, but you may not qualify now or may want to do it later, there's a big window of opportunity to enroll in the next year and a half. But I think
Yeah.
your question was about Botox, so I'll stop there and then
Yeah, let's actually talk about pelvic pain and then as it relates to the study, and you can explain the study
okay.
further. So, what kind of patients, what kind of symptoms, what would a patient like typically look like who would come in and would possibly be a candidate for Botox being a part of their plan of care?
So pelvic pain doesn't mean one thing. There's a lot going on in the pelvis and many potential causes of pain. So to answer that, I think thinking about the structures and function of the pelvis is the first thing. So you have your organs like the bladder, the reproductive organs, the uterus, the ovaries, cervix, vagina, and then the vulva is the external. Um, then you have your pelvic bones, which are connected to your spine and your legs. And these connections, which are joints, are secured by connective tissue. You have your blood vessels that are carrying nutrients and oxygen and hormones to all of these organs. And you have your nerves from the spine that are communicating between the organs and the brain. So there's a lot of coordination and communication and organs and a lot going on. And then you have the muscle groups, which you know as a physical therapist. There's a lot of muscle groups in pelvis. One of them is the pelvic floor, which is like the bowl of muscles that's at the bottom that supports the organs, and it also helps coordinate their functions. So if these muscles at the floor are too loose, you can get um, incontinence. That's not the ideal patient for this study. The ideal patient for this study is someone who has their pelvic floor muscles are too tight because the tightness causes pain. When muscles are too tight in the pelvic floor muscles, they cause pain because they constrict blood flow. So there are blood vessels that run through these muscle groups, and they kind of cut off that blood flow when they're really tight. And so the tissue overlying these muscles will become painful because what blood carries is oxygen and nutrients and hormones to the cells. And without oxygen, the cell move into a process called anaerobic respiration, which you may recall from biology. Basically, the cells um, create energy in a different process, and the byproduct is lactic acid. And lactic acid burns. And when you work out and you feel that muscle burn, that's the lactic acid production. So that's what's going on, like in the pelvis and the pain versus, weak versus tight muscles, which I think is one distinction we have to make regarding this trial. The other key piece of anatomy that put this picture together for me when I started working at this job, I did not learn this in school about the pelvic floor muscles, is that they have attachments in the back of the vagina and the vestibule, which is that small area of tissue at the entrance of the vagina. It's between the Hart's line and hymen, which is if you separate the small lips called the labia minora, and you put your finger about like one knuckle deep, then you're in vestibule territory. So muscles attach at the bottom part of this. So that's um, important to know. Really important to understand in evaluating anyone who says they have pain with sex, pain with tampons, pain with speculums, pain with tight clothing or sitting or anything that touches that area. You have to assess whether that pain is only in the muscle groups that are where the muscles attach, which is at that bottom half of the vestibule, or is there pain elsewhere? So if there's pain up by the urethra or other places in the vestibule, the Botox is not going to be the right treatment for that person. So it's very possible, and it's also very common to have more than one cause of your pain. So you might have uh, multiple things going on. Pelvic floor muscles may be tight and be contributing to the pain. But you want to address those other sources generally first before we target the muscles. Um, because if you have something like an autoimmune skin condition that's causing you all this pain all the time, even if you give Botox, the muscles are still going to have a hard time relaxing because you're in pain for another reason. Um, so I think once you identify like the location of the pain and understand that the pelvic floor muscles are involved. Um, you then want to think about why their pelvic floor muscles are got into that place. Um, I can talk more about how I think about that.
Yeah.
I think I got off track with your question, but
No, that's perfectly on track. I actually really love that you explained that. Hopefully, listeners, I know there's a couple of terms that you use, like heart line,
yeah.
that maybe people don't fully understand. But I think, tell me if I summarize this correctly, that pelvic pain can be coming from various causes, right? So it could be coming from a muscular reason, it could be coming from a dermatological reason, so that would be related to the skin. It could be coming from a nerve disruption of some kind. That's usually coming from the lumbar spine and the sacrum. So the lower back is where the nerves come out of. So there could be a nerve dysfunction. There could be all the like basically different structures. There could be a ligamentous or a bony injury. That could be referring pain and reproducing pain in the pelvis, like you mentioned. So because there's all those structures, the bones, the ligaments, the blood vessels, the nerves, the muscles, pain can be coming from a disruption of any of those structures. And specifically with pelvic floor muscles themselves, their location makes them basically susceptible for pain and dysfunction and issues with bowel, bladder, and sexual function just because of the nature of where they are. So if somebody's coming in who has female anatomy and so they're having pain with some kind of vaginal penetration, like you mentioned, the speculum, the tampon, penetrative intercourse, things like that, then one of the things that you should be thinking about is there pelvic floor muscle dysfunction? Because there's other kinds of pelvic floor dysfunction. Like for example, I've like mentioned this in my course as an example, and tell me if you agree or have a comment on this. But I've had patients coming in with like straight up urinary urgency, frequency, incontinence, and there's absolutely nothing wrong with their pelvic floor muscles. They're just doing something absolutely insane with their diet soda and their iced coffee and like not
Hmm.
eating food
Hmm.
and just like constantly peeing and leaking because they're over
Hmm.
fluid intake is just too much for them.
Hmm.
So we
Yeah.
changed their nutrition, and so that affects their
Hmm.
pelvic floor. But they had good pelvic floor muscle coordination on an exam, right? So I don't know if you could comment on how, or like continue to elaborate on how there could be many sources for pelvic floor issues in general. But when there's pelvic floor muscle dysfunction, and that muscle dysfunction specifically comes from an overcontraction or a tightness of muscles where it's stuck in a tight space and has
Hmm.
lactic acid development, that would be a good person for the things that we're about to discuss in a second here. Does that sound right to you? Did I do that
No, it sounds
well?
right. I think you asked a question there. I guess I think of the causes of pelvic floor muscle dysfunction or hypertonic pelvic floor muscles as a few different categories. So one of them is guarding. So if you have pain from recurrent infections or a skin condition, the natural response of the body is to guard, to protect you. So your muscles are trying to protect and serve you in some way, but they get trapped in a cycle that they cannot get out of. So it can be starting with guarding. The other category we see a lot is compensation, is how we think of it. So especially in the hypermobile patients. So the pelvic floor helps support all of these, has connections to all of these bony structures and helps support them. So if you have a joint that is very hypermobile, and the reason they're hypermobile is, as you know, because the connective tissue can be very stretchy. And so if that connective tissue is stretchy, then you have an unstable joint. And the body subconsciously, their muscles will contract to support that joint so that you can walk and move and not be wobbly. Um, so the pelvic floor muscles can get in a chronic state because they're constantly supporting an unstable joint. So Botox can get them out of that cycle, but then they have to learn how to strengthen the muscles around the joint, because if you are a hypermobile person, you don't want floppy joints because that leads to injury and pain. You want to have control over your joints, and that's when it comes down with your to strengthening. And you work with someone like you, physical therapy, to learn that about your body. But it gets the other group of reasons why pelvic floor muscles can get into this chronic cycle is behavioral. So if you're someone who holds your urine all day, or if you're someone who does a lot of intense core workouts, someone who just generally holds stress in that part of their body, we see a lot of connection between jaw clenchers and people who hold their stress here in their jaw will also hold it in their pelvis. They're like kind of floors that mirror each other. So you have the jaw, the diaphragm, and the pelvis. And so learning how to breathe with your diaphragm and relax that is also helpful for the pelvic floor. So I think the guarding, compensation, and behavioral causes are usually what gets people into these cycles. Botox is so great at relaxing that it creates this window of opportunity for PT to make it for the muscles to make accelerated progress. It's not necessary for everyone to get out of this cycle, but a lot of people need some muscle relaxant in addition to the physical therapy that they're doing.
Absolutely. I love this conversation and geeking out to this. And it's really nice to like speak with a non-pelvic floor PT in this way because
Hmm.
obviously, as you know, there's like not a ton of healthcare providers and medical professionals who understand this field so well, Charlotte. And the way that you explain it is so perfectly, beautifully understandable to listeners, or at least I really hope that it is, because this is the same way that we talk about it as PTs, is there's so many causes for pelvic floor dysfunction, and then when there's a muscle issue, there's different types of muscle issues. Like we spoke just about tightness and weakness, but it could be coordination, it could be endurance, it could be sensitivity, it could be other things too, or a combination of them. And then why is that happening in the first place? And you just beautifully described how it could be because of the guarding, the compensations. And we see this a lot in our clinic where sometimes it's one thing and sometimes it's a little blend of a couple of different things, especially if it's been going on for so long. So then I always say to people, like, it's kind of like a chicken or an egg situation at this point because I didn't see you 10 years ago when this first started presenting to you. And there's been so many changes, but here's what we see right now. What we see, what we treat, what we see. We treat what we find and we use our best clinical judgment. And
Hmm.
as providers who actually like physically work inside and outside of the pelvic floor structures, having a really good understanding of the structures in the first place, how they function, and what does dysfunction look like is really important. Because if you don't, then you turn into what Charlotte mentioned earlier, a provider who might just you might bump into a provider if you're a patient listening, or if you're a provider listening who doesn't treat it, you might be compelled to say, I don't know what's going on, or maybe it's in the patient's head, or bump them off to maybe the wrong referral source because
Hmm.
and that person might also not understand. So this starts this
Yeah,
cycle of people just suffering unnecessarily. So
uh, well said.
yeah.
Completely agree.
Yes. So let's dive into a little bit specific because I know we talked about the Botox, we talked about like what kind of a candidate
Hmm.
would be able to benefit from this. What are some other things that you offer other than Botox in your treatment strategies, and why would you offer them as maybe a comprehensive plan of care for patients? So stepping away from the study just a little bit.
It's specifically for hypertonic or tight pelvic floor muscles.
Yep, exactly.
We also have muscle relaxants that come in suppository form. So you can do a suppository of Valium, diazepam. And so that's inserted either vaginally or rectally, depending on where which muscles we need to target more. And they're absorbed mostly locally, right in those muscle groups, a little bit of absorption in the bloodstream. So, um, I mean, that's really the first. muscle relaxant I would start with is there's others like called another one is baclofen, which we can do for pelvic floor dysfunction. So starting with something that's less expensive. Botox is expensive, and Botox requires injection. It's a very, very thin needle. It's the size of an acupuncture needle, but it's not zero pain. It's not, you feel the poke and you feel some burn for about 4 seconds. So we try to avoid that initially, unless someone has already tried everything and they're ready for the next big gun muscle relaxant that will go to us, but it's usually not the first.
Yeah. And then, of course, we want to make sure that, as you mentioned, helping patients understand, right, like why they're having their symptoms can be
Yeah,
actually one of the first pathways to helping them heal. So,
yeah,
explaining to them that even if you do this Botox and then you don't understand how to relax your pelvic floor muscles and relax your jaw and take deep breaths, as soon as the Botox wears off, it's going to literally just like go back to
oh
how
yeah,
it was. And
yeah.
so, giving patients that education of that behavioral change, I feel like can be
Mhm.
so beneficial from day one. Um,
Absolutely. I
I
don't think we
do
have the conversation about Botox or muscle relaxants in general without talking about how you need to retrain your muscles and get
exactly.
them back to their natural happy place.
Yeah. So first, I almost anybody who's a patient listening right now will be like, "Yeah, I know." But my two things that I tell anybody on an evaluation, no matter who they are, whether they're coming in for knee pain or back pain or headaches or shoulder pain or pelvic pain, it doesn't matter. But I tell them two things. It's one, I just need you to start become hyper aware of how you are holding your body in like all of your body. And
Hmm.
then if especially if it's somebody coming in for back, hip, pelvic stuff, I'll tell them, I
Hmm.
need you to become hyper aware of where your pelvic floor is. And I would have explained to them with usually an intravaginal pelvic floor muscle evaluation
Hmm.
on that day of what those different states of the pelvic floor are and how you move them
Hmm.
and help them. I'll usually say, don't change anything. I just want you to understand and begin to bring awareness to it. And then usually come in the next session on session number two, and they'll be like, I had no idea that I was doing, and then go into like what they took notes on. Whether that could be, oh, I didn't, because I'll explain them various scenarios, and they'll be like, I didn't realize that I was just like curled up on the couch watching TV for 2 hours on my left side, and then the whole night I can't sleep because I have left-sided like pelvic girdle
Hmm.
pain and lower back pain,
Hmm.
and I'm sleeping on that side too. And then all these things are like, it's if there's so much that we can do that will help us. And once we become aware of what we're doing in the first place, that could be
Hmm.
changed. That's almost the most powerful thing that people can understand, because it's something that they have control over. Whether they think they do or not, they really do. It's just this
Yeah.
awareness that needs to build. And so providers like us give you that awareness because we can teach
Yep.
you what the space is in your body, which feels so a shameful, B confusing, C hard to get to literally
Hmm.
physically. And so that connection is what we do in different practices in slightly different ways, which is really cool.
Yeah, no, I agree. As you were talking, I was checking in with my own positioning and tension and where it is. Yeah, you have to be sort of guided and educated and reminded to tune in and learn these things. So that's why
Yeah.
I love physical therapists. Can't do our job without you, we always say.
We
Um,
can't do our job without you.
it's teamwork.
Exactly. I love it. Charlotte, do you have anything else to add to our conversation today? Anything else you think that is important for listeners to learn about our topic, about your study, how to find you guys, things like that?
Um, I think so. One of the most important things for any physical therapist listening is that um, so if someone is interested in participating, we will want them to have a diagnosis from a physical therapist or expert who knows how to assess the pelvic floor muscles and knows that they're hypertonic. We will then confirm when we see them that their pain is only in the back part of the vestibule called the posterior vestibule. So I do a Q-tip test to confirm that. If they have pain elsewhere, and there's other causes of pain going on. We don't want them participating because they need, multiple other forms of treatment. So that is one of the main criteria to be included. We are enrolling women who are 18 or older, and who are premenopausal, and who are not pregnant, breastfeeding, or trying to become pregnant. So we do a urine pregnancy test before any injections. We're just not studying for safety and pregnancy. You are allowed to be in physical therapy, and you are allowed to be doing home exercises when you're enrolled in this trial. We actually request that if you are in physical therapy, that you continue throughout the trial and that it doesn't change. So if you're going weekly, we want you to continue going weekly. And we don't want you to start immediately before the trial, because then we don't know if the benefit is from the Botox or not. So if you are in PT, you need to be in PT at least for 2 months before enrolling. And that includes also home exercise. If you're doing home exercises, we'll ask you to be consistent for about 2 months before you start enrolling. If you've ever had pelvic floor Botox in the past, that's okay. You just cannot have had it in the past year, but you can still enroll. And if you use muscle relaxants, you would just have to stop them 2 weeks before enrolling in the trial. Um, the It will be up to like the clinician's judgment if there are other like causes of pain that would exclude you. But if you're interested, I would um, contact our research email, and you'll get a call from our research coordinator, and they can go over all of these details with you and talk to you about whether or not you'd be eligible before you even come in for a visit. Um, then what would happen is you'd come in for a baseline visit, and you wouldn't have any injections on that day. We would just confirm that you're eligible. Then you would come back 2 weeks later, and you would get your first series of injections. You will either be randomized to receive the Botox, or in this case, Botox is a brand name. We're using the same toxin, but made from a different manufacturer. So it's not called Botox, but it's the same. You either receive the Botox or you receive the placebo, which would just be saline injections. And so I don't know what you're receiving. You don't know what you're receiving. It's double blinded and it's randomized. So 50% of people will be placebo, 50% will be the drug. Um, then 6 weeks later, you come back for a second series, and then you will have 2 more visits that are just follow-up visits. And we assess how you progress by doing a dilator test in the office, and by also doing questionnaires that you'll fill out. So the dilator is a validated way to measure pain with penetration. So it's like you start with a very small dilator, and then it increases in diameter, and that's how we measure your progress objectively. Then at the end of the trial, if you were randomized to the placebo group, you'll actually have the option to then get the medication for free. So everyone who enrolls, I like talking about the study because for a few reasons. Everyone who enrolls gets the drug. Um, you may have it initially, or you may have to wait until after. Um, we've been doing Botox for pelvic floor, hypertonic pelvic floor for 20 years at least, I think. Like it's we know it works, but we need the studies to demonstrate the effectiveness, and also to then get FDA approval so that insurance will cover it. So that's really what's also very exciting. And my boss, Dr. Goldstein, has been fighting to do this for 10 years, I think. And we finally have interest from this manufacturer who's enabled us to do the study now. So, um, yeah, I think that's all I have to share right now about
Oh.
we spend most of our time talking about Botox, and pelvic floor, not the study, but please include the research emails that I'll send to you so that anyone who's just listening who's interested can reach out to our research coordinators, learn some more, find out if they're eligible, and get
Yeah.
some free Botox and
I
get out of
love
pain.
that. Yes, I will include, Charlotte will send me the research email, which I will drop in the show notes for listeners, along with CBBD's website, just in case you are curious about the center's services and want to book an appointment for any other reason, because they treat more than just hypertonic pelvic floor dysfunction. There's lots of other things that um, this particular clinic treats as well. So the website actually does a very beautiful job. I sent some patients there just to help them explain various conditions because you guys have a
Mhm.
nice little pretty diagram of explanations where you can click and then it
Yeah.
expands and helps people understand like what is pudendal neuralgia, for example, like that's a nerve dysfunction. And then I think there's like a lot of those. So for people who are just curious about hearing different types of pelvic issues, I actually send them there to just like a very credible way to help them understand. So I'll drop that on the show links as well.
Okay.
Charlotte, thank you so much for talking to our listeners and spending your very valuable clinical time with us to help us understand these concepts. And we really hope that if you're a listener, that you gained something, that you understand something differently, whether you're a patient side or your provider side, and that if you're interested to enroll in this study, um, this particular episode is coming out in summer of 2026. So you'll have like a full year of enrollment that you can do. And so if you're interested, please do reach out with the information in the show notes. Thank you so much, Charlotte.
Thank you, Sneha. It's good to see you.
Good to see you too.